Today, I am going to discuss Warthins tumor. Now, these are four pictures. All these pictures have certain things in common. Number one, there are swellings in the region of posterior part of mandible. Number two, the swellings near or below the earlobes. Number three, the swellings are round or ovoid. Number four, they are slow growing and painless, going by the history of the patient. Number four, they are mostly adults and they are males. And number five, these swellings are quite small. Here again, this picture depicts as a swelling below the lobe of the ear. It's a nodular swelling, is rubbery in consistency, and it is posterior to angle of mandible. And this swelling again is asymptomatic. Lots of such swellings were studied by different researchers and in 1895 were termed as variants of congenital epithelial cysts of neck. Many of these swellings were called as papillary cyst adenoma, if known the year 1910 by Oz et al. Going by the name of the tumor and its definition, there are some unique features of these swellings. Number one, histopathologically, they contain lymphoid tissue. Number two, they have got a prominent epithelial cell layer. Number three, these have got cystic spaces. Based on these characteristic features, they were called as adenolymphoma, but this term was not accepted because this didn't reveal all the unique characteristic features of the lesion. They were also termed as cyst adenoma lymphomatosum. Lymphomatosum indicated that lymphoid tissue surrounds the neoplastic area of the tumor. They were also termed as cyst adenolymphoma, and some researchers termed these as papillary adenomas. None of these names were found to be satisfactory, so Warthin in 1929 described this tumor in more detail and he called it as papillary cyst adenoma lymphomatosum. Here, the term papillary meaning that epithelium going in the cystic space as prominent folds. So, the tumor was called as Warthin's tumor after his name. The definition is that these are adenomas composed of bilayered columnar and basaloid oncocytic epithelium that form multiple cysts, numerous papilla, and accompanied by lymphoid tissue. This definition also three important unique components are seen. The etiology of Warthin's tumor is largely unknown, but they are associated with smoking, Epstein-Barr virus, autoimmune disease, and radiation. Warthin's tumor have been found 8 times more frequent in smokers. Many studies indicate that there is positive correlation between smoking and Warthin's tumor. About 90% of Warthin's tumor patients are smokers, and it is believed that there is metaplasia in gland due to various irritants in tobacco smoke. Regarding its etiopathogenesis, it was initially proposed that there is prominent epithelial proliferation leading to formation of lymphocytic infiltration. But subsequent studies indicated that there is induction of cystic and oncocytic changes secondary to inflammatory infiltrate. Based on this, brachygenic theory was proposed, which indicated that the remnants of brachial pouches lead to formation of Warthin's tumor in the region of neck. Based on the contents of lot of lymphoid tissue, the delayed hypersensitivity theory was proposed, which indicated that Warthin's tumor is due to reactive inflammatory response secondary to neoplastic epithelial changes. Yet another theory indicated that there are ectopic Stachyon tube endodermal tissues which lead to formation of Warthin's tumor. But the most common accepted theory is heterotropic salivary gland duct theory, which indicate that there is entrapment of salivary ductal tissue in lymph nodes during embryogenesis in intraparotid or paraparotid region. Here we have to remember that in the region of parotid, lot of lymph nodes are associated with it. The lymph nodes are seen only in the region of parotid because it is believed that during embryogenesis there is late encapsulation of parotid leads to development of lymph nodes the region. Now coming to the epidemiology, among parotid, Warthin's tumor account for 2 to 15% all benign neoplasm. Now we all know that in parotid, pleomorphic adenomas form around 75 to 85% of benign neoplasm. So, Warthin's tumor is second common tumor of parotid. Some studies do indicate that they account for 4 to 25% of all salivary gland tumors, and 15% of the patients develop more than one Warthin tumor. Warthin's tumor is mostly found in 6th and 7th decade of life. It is very rare for 40 years of age. The males are more affected, and it is common in 7th decade of life, in one study, and in females it is seen earlier, that is it is found it is seen in sixth decade of life. Regarding male female ratio, earlier studies indicated that it is found more in males than females in the ratio of 10 is to 1. But recent studies, particularly in European countries and US, indicate that the ratio has changed due to increased incidence of smoking in women, and it is 0.6 to 1. Clinical features of Warthins tumor. We all know it is an adenoma, meaning thereby it is a benign tumor of glands. Their salivary glands is common in parotid, and in parotid common in superficial lobe. It is painless, as I have already discussed it. It is round or ovoid, and the swelling is very slowly increasing in size. It's gradual swelling, is slightly mobile, is very rare in deep lobe. Some studies indicate that 5% or less may be seen in deep lobe, but nevertheless, it is very, very rare in deep lobe. It is firm, sometimes it can be duffy, and most of the times it is rubbery in consistency. The facial neuralgia, very rare in Warthin's tumor. Very rarely it causes pain, deafness, or invasion of surrounding tissues. The Warthin's tumor are not fixed to adjacent structures. Warthin's tumor account for 70% of bilateral salivary gland tumor. So, one more characteristic feature of Warthin's tumor is that bilateral, they are bilateral, and among all salivary gland neoplasms, these are the most common bilateral salivary gland. Roughly 10% of these are bilateral. In a 10%, the range is 5 to 50. They may occur synchronous with pleomorphic adenoma, salivary gland, salivary duct carcinoma also. Once the tumor is excised, the features are that there is prominent capsule, the color is pale gray or white, ovoid or spherical. Multiple cystic spaces are seen. Discrete brown or white exudate is considered mostly serous or mucinous excretion of parotid. Histopathologically, we have already discussed there is a prominent cystic space, and this cystic space there is bilayered epithelium. Uh, there is tall columnar cell layer, and second layer is cuboidal cell layer. Bilayered. Thirdly, there is prominent lymphoid tissue here, the lymphoid tissue, and there are prominent papillary projections. These are in the tongue, sorry, finger-like projections. These are called as papillary projections, and hence the name papillary cystadenoma lymphoma. This is the other picture. Again, reveals a prominent epithelium. Then there is lymphoid tissue, prominent lymphoid tissue. And thirdly, there are lots of cystic pieces. All are cystic pieces. Higher magnification, double layered epithelial cell layer is prominent. One layer is of tall columnar cell and another cell layer is of cuboidal cell. Nucleus here is vesicular and here nucleus is palisaded. That means nuclei are arranged almost at the similar level. So this is bilayered epithelial cell layer which is prominent here. The tall columnar cells having nucleus arranged at the similar surface. Then other layer is cuboidal cell layer. Then there is a prominent cystic space. This cystic fluid space is there, contains fluid or contains eosinophilic coagulum. And then already told you this is prominent white tissue. So to summarize, the salient microscopic features are cystic spaces, supporting stroma composed of lymphoid tissue. There is bilayered luminar epithelium, and the cytoplasm is granular, contains mitochondria, and is positive for PTAH stain, that is phosphotungsten acid stain. As I already told you, there is eosinophilic coagulum, and the lymphoid tissue is normal, which involved both humoral and cell mediated mechanisms. Less common histopathological features are that they rarely contain cilia. Then there is infarct like necrosis very rarely, dendritic cells, mucin secreting cells, and sebaceous cells. Sometimes these sebaceous cells are so prominent that sebaceous type histopathological variety of papillary cyst adenoma lymphoma common. So, histopathological variant of Warthins tumor is sebaceous type of papillary lymphomatosis. CT findings include well-defined margins, superficial lobe of parotid, and heterogeneous contrast enhancement. The cellographic findings are similar to that of pleomorphic adenoma, which is ball and hand appearance. Scintigraphy, high mitochondria accounts for its high uptake in technetium 99 scanning. It appears as hotspot on scintigram. Differential diagnosis, pleomorphic adenoma based on the location, oncocytoma based on the location, lipoma because is duffy, soft, sometimes soft, mobile. Then there is malignant lymphoma, then enlarged parotid lymph node, and again based on the location, important differential diagnosis can be cynic cell carcinoma. Treatment is by surgery, there is surgical excision or superficial parotidectomy to remove whole of the capsule. The prognosis is by and large good, and it very, very rarely transforms in carcinoma, expapillary, cyst adenoma, lymphomatosum. Again, is very, very rare. Some studies indicate recurrence rate of as high as 6 to 12%, but most of the studies agree that recurrence rate is less than 2%. Malignant transformation, as I have already told you, is very rare. It is less than 1%. Thank you. Bye.